Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Mosaic.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Welcome to the Egg Whisperer Show. I have Dr. Lucky Sekhon on with me today. Hi, Dr. Lucky.
Hi, thank you for having me.
Of course. And you also have a pretty cool website. What is it? myluckyegg.com. Is that what it is?
TheLuckyEgg.com.
TheLuckyEgg.com. Everyone, you got to go to it. Tons of great information. And we're going to talk about genetic testing and fertility, what you should know before trying to conceive. I think everyone should listen to this episode, don't you think?
I do. I think it's an often ignored topic, but it's so important.
And where do you live?
So I'm based out of New York City. I live in Brooklyn, but I practice at RMA of New York, which is a large IVF center in the middle of Manhattan, and we have 6 different locations. I'm based downtown in Soho and in Midtown East.
Wonderful. Let me just read your bio for the folks who don't know you as well as I do. So Dr. Lucky is a reproductive endocrinology and infertility specialist. She's a baby maker just like me at RMA, just like she said. She was born and raised in Toronto, Canada, and moved to New York City to complete her OB/GYN residency training. And she's here to talk about genetic testing and fertility. So why did you choose reproductive medicine as your focus in medical school?
So I always knew that I wanted to go into women's health, and I don't really know exactly why. I think it's because I grew up in a female-dominated household. I have sisters, and my mom's a really strong influence in my life. So I feel like women's health has always been very top of mind. But then specifically within OB/GYN, I was really drawn to the field of REI, or infertility, of fertility medicine, because it's amazing, right? Like IVF was invented not that long ago. And I just feel like it's such a fast-paced, growing field, and the cutting-edge research really spoke to me. I am still active in research. It's a passion of mine. And I just love that the things we're debating and looking into and investigating today are becoming part of standard of care a year or two from now. And that to me is really exciting.
I agree. It is very exciting. And IVF has kind of touched you personally as well. How did you guys grow your family?
So I have 2 daughters, a 4-year-old and almost a 1-year-old, which is crazy to think. And I started my family in my mid-30s. Like a lot of women, especially those, who have been putting aside maybe their personal goals to build their careers and, to go through training or education. I waited, and that made me nervous, especially being in this field and seeing all the things that I see. So I decided to undergo fertility preservation, and my husband and I froze embryos right after we had our first, right after I finished breastfeeding. That was the first thing I did. And it was really important to me because I didn't want to feel rushed to have another when I wasn't ready. And now being 38, I'm so glad that I have those frozen embryos. I just had my daughter Gemma last year during the pandemic. Wasn't really my plan, but it all worked out, and she's healthy and beautiful. But it really, speaks to me when I see my patients. A lot of them are in the same age group, in the same phase of life. And secondary infertility is a very real thing. Even if you start out in your mid-30s and it works out that you're able to get pregnant with your first, just because of the amount of time it takes to be ready for that second child, if that's something that you want for yourself, because of the challenges of biology and time, it can be more difficult. And I just didn't want my biology to be the determining factor.
Yeah, I always say it's always nice to have embryos on ice. There should be t-shirts that we hand out at the grocery store. So, no. So I want to talk more about genetic testing today. And I feel like when I just say genetic testing, people really don't know what that means. So let's get into it. Like what people really need to know before trying to conceive. What are some of the basic things that people should know about genetics?
I totally agree with you. I feel like when people hear genetic testing, they kind of shut down. It either seems really complicated and boring, or it sounds scary. But it's really simple, and that's what I'm hoping we can break down for everyone today. There's different types of genetic testing. So when we say genetic testing, it's a very general umbrella term, and we might be talking about very different things. So to start out with the first category of tests, there's what you can do pre-conception or when you're already pregnant. And I refer to it as a risk assessment tool, where we can draw blood on yourself, and if you have a partner, your partner, or on sperm donors or egg donors, and we can determine what mutations, if any, they carry. And that's another word that scares people, mutation, right? But what I explain to everyone is that it's very common to carry a mutation. A lot of, the genes that we have, we're supposed to have two copies, and it's not uncommon to carry one mutated copy of a gene. And for the most part, for a lot of disorders, it doesn't really matter, right? As long as you have one functioning copy. And so we just want to know what mutations you carry. As a human being, it's normal to have a mutation, and to make sure that you don't match up, that you don't carry the same mutation. Around 2 to 4% of the couples that I see are what we call joint carriers, meaning they both happen to carry the same type of mutation. And in those rare cases, you have a 1 in 4 chance of having a child with two copies of the mutated gene. And that means you have the actual disease that gene mutation corresponds to. Examples are things like cystic fibrosis, really serious lung condition, congenital deafness, but the list goes on. And we were just talking about this earlier. Now, one of the biggest panels that's out there that a lot of us use has just included 500 different types of conditions and the associated mutations. So it's not trying to diagnose anything in you, right? This isn't something that insurance companies can use against you to say that you're at increased risk of developing a disease later or anything like that. Those are the typical worries that I hear about. It's a risk assessment tool to see if there's any chance that you and your partner could contribute to mutated copies and have a child potentially that could have any of these conditions on the panel. Some of the conditions don't really work like that, and that's a little bit more complex, but X-linked conditions, right, where a woman can carry one of these mutations on one of the X chromosomes. So if she has a son and they inherit that one X chromosome and the Y from the dad, the condition could manifest in that case too. So before you get this blood test drawn, you'll be counseled and given a list of what conditions are covered on the panel. And when you get the results back, you'll get a call from a genetics counselor and they'll explain what all of that means. But the main thing is just ruling out that you don't carry the same thing. Now, if you do carry the same thing, that is useful information, because you could say, all right, well, now I know there's a 25% chance that I'm going to have a child with X disease, right? What can you do with that information? You can do nothing and say, I'm going to just go into the pregnancy with eyes wide open and know that this is something that I could test for at 11, as early as 11 to 12 weeks or later in the pregnancy, and then make a decision if we find that the pregnancy is affected of whether I want to continue the pregnancy or not. You could say, I want to be proactive and not find myself in that situation where I could be, pregnant for the entire first trimester and worried and wondering if this baby's affected. So you could preemptively do IVF, create embryos, and then genetically test the embryos in a very targeted fashion to figure out which embryos carry the condition, which embryos have two copies of the mutation and have the actual disease, and which embryos don't have any copies of the mutation. And that's called pre-implantation genetic testing. There's lots of different types of testing that can be done on embryos, but that's one focus test that you can only do if you know what you're looking for. So that's why we do this carrier screening on prospective parents.
And I love what you called it. You called it joint carriers. Is that what you said?
Yes, yes.
I think it's a lot better than saying you're genetically incompatible.
Right, exactly.
But joint carriers just sounds like you're in it together and you're going to get through it together as well. So when it comes to eggs, like what's happening over time from a genetic standpoint?
We talked about pre-implantation genetic testing. I'm sure many of the people tuning in today have heard that term, PGT, and it's most often not used to test embryos for a targeted gene mutation, right? I would say the most common use of PGT is to count the number of chromosomes in each embryo. And that is a very common problem, that you can have an embryo form from sperm and egg that doesn't have 46 packages of DNA or chromosomes. And if you don't have 46 chromosomes in an embryo, one of three things is going to happen. Either it's going to stop growing before it can even get to the wall of the uterus and implant, and you just don't get pregnant that month, right? If the egg that you ovulated was abnormal and, turned into an embryo that didn't have the right amount of DNA, it might just stop growing and not actually turn into a pregnancy. It could also implant and then stop growing, and that's the number one cause of a miscarriage. And then there are very few types of typos or errors, I call them, that are actually compatible with life. But an example is Down syndrome, right? You could have 3 copies of chromosome 21, and that can result in a live birth of an individual that has significant medical problems as a result, right? So those are the 3 different things that can happen. Why is it so common to have embryos form that don't have 46 chromosomes? A lot of it comes down to the egg, right? In your original question, which is what's happening to the eggs? Well, we're born with all of the eggs we're ever going to have, right? And we can't fix our eggs or repair them over time like a lot of the other types of cells in our body. And so we accumulate tendency, we start to accumulate errors in the eggs, and there's an increased tendency for us to lose chromosomes or gain extra chromosomes in our eggs as the egg is growing and dividing, and it goes through different stages of development. And as you age, it becomes more common to release an egg that doesn't have the 23 chromosomes it's supposed to contribute to that 46 chromosome embryo. And no one is immune. This is what I always tell my patients. No one makes perfect embryos, right? When you were in your 20s, what we see when we look at our PGT results from women going through IVF in their 20s is that about 20 to 25% of those embryos coming from a woman in her 20s to early 30s are going to be genetically abnormal. Either they're missing chromosomes or they have extra chromosomes. At 35, we start to see rates of about 30 to 35% of embryos having the wrong number of chromosomes. And at 37, 38, that's when we start to see a real uptick. You start to approach rates of about 40 to 50% of embryos being affected and not having 46 chromosomes. And at 40, it's like 60 to 70%. And at 42, 43, we start to approach 80% and more. And that is why there's a link between age, female age, and infertility, female age and miscarriage. It comes down to this fundamental fact of the embryo just didn't have the right amount of DNA to grow and persist as a healthy pregnancy. So that's what's happening with age. And the good news is you can use this technology, PGT, where you're basically capitalizing on the fact that an embryo has 100 to 200 cells. By the time it gets to day 5 of development after fertilization, a lot of the times they separate out into 2 cell types if it's growing at a normal pace or it's a fast developing embryo. And you can remove some of those placental cells, the cells that will one day become the placenta, and send them off for genetic testing and count the number of chromosomes. You can tell if it's going to be a female or male embryo, and you can also look for a mutation in a targeted fashion.
And you brought up like Down syndrome, and I'm sure you get this as well. Patients leave your practice, they've done the genetic testing of the embryo, the PGTA, and then they email you, did we screen for Down syndrome? So can you talk a little bit about the difference, and or not the difference, but what is Down syndrome? What is Turner syndrome? And how is that related to the chromosomes?
Right. So Down syndrome is when you have 3 copies of chromosome 21, right? There's 23 different types of chromosomes. There's the sex chromosomes, and then you go from 1 to 22 in numbers. And if you have 3 copies of chromosome 21, for whatever reason, the genes that are on those particular chromosomes, having that imbalance doesn't prohibit the embryo from implanting and turning into a pregnancy, and you can actually get to a live birth. But individuals with Down syndrome, have a shortened lifespan. A lot of them have cardiac malformations and a host of other medical problems. And it's this lifelong thing that you deal with. And you can screen for this in early pregnancy. So I don't want patients to think that the only way to prevent this is doing IVF and genetically testing embryos, right? This is something that can be screened in the first trimester with blood work, ultrasound markers, which can be done at the end of the first trimester. And then you can do a chorionic villus sampling or CVS at the end of the first trimester, or an amniocentesis during the second trimester. And these are invasive, but generally speaking, associated with a low rate of complications and can give you definitive information about the genetics of the pregnancy. So you always have the option to do this testing to understand more about the health of the pregnancy. Turner syndrome, I didn't answer that. That's where you're missing an X chromosome. And similarly, it can cause a host of problems affecting kidneys, intellectual function and ability, height, all sorts of, the body systems are affected across the board.
And if a patient says to you, well, we don't have Down syndrome in our family, why would we need to check for this? How would you respond to that?
Well, it goes back to what I said at the beginning, right? There's so many different things that you can test when you think about genetics. And the things that run in your family, that refers to those gene mutations and the things that we can pass on. But these chromosomal count errors can happen to anyone. It has nothing to do with the genetics of your family. It has more to do with age.
Yeah. So what are the three like big categories of genetic testing that you do as a fertility doctor?
So carrier screening on patients, individuals or couples. This can be done prior to getting pregnant. A lot of the times people will get pregnant on their own and just go to their OBGYN and get this testing done to determine if they should be doing any more detailed testing on the pregnancy later down the line. Pre-implantation genetic testing, which is testing on embryos, right? So this involves biopsying an embryo, removing some of its cells and sending it off for analysis. Most places are freezing the embryo to wait for the turnaround time for the results. And then the third category is something that hasn't come up yet, and it doesn't really impact most individuals, but this is called a karyotype. And this is a test where basically blood is drawn and the cells are fixed on a slide and looked at under a microscope so that someone can actually analyze the structure of those 46 chromosomes. And by doing that, you can learn a lot. You can learn a lot about whether all 46 chromosomes are present, right? If there's any structural rearrangements, believe it or not, you can have a breakage in the chromosome where for some reason a piece of one chromosome got translocated to the end of another chromosome. And you could be a completely healthy individual because you have all your genes, right? You have the right amount of DNA, it's just rearranged. But what happens if you join your DNA with a partner or an individual's, there's going to be a higher than expected rate of abnormal embryos that have imbalances in the proper amount of DNA they're supposed to have. Inversions are when there's a section of a chromosome that's flipped. Again, similar situation. You have all the right amount of genes and DNA that you're supposed to have as a human being, but when your DNA joins with that of another individual's, there's going to be a higher than expected rate of errors. And so this is something that is first line testing done in couples or individuals who've had recurrent miscarriages, because sometimes recurrent miscarriages can happen because of chromosomally abnormal embryos that resulted from one of these structural rearrangements. But we were talking about this earlier, that we often, as reproductive endocrinologists, will think to do this testing on patients who, don't do as well with their IVF cycle as we expected them to, right? So an example is, let's say a 31-year-old who has 10 fertilized eggs to start with and nothing grows to the blastocyst stage. And you're thinking, why would there be such sharp drop off? The number one cause of why embryos stop growing in the lab is that they were genetically abnormal. That's one of the common causes. And so you may do a karyotype on that person, on that individual and their partner, to see if either of them have any of these issues that could explain why none of the embryos made it. Anytime I have a patient who has really diminished ovarian reserve at a young age, I might do a karyotype on them, because sometimes you can have, and this is where things get more complicated, not all of your cells have an abnormal number of chromosomes, but some of them may. They might be missing that X chromosomes, and you could be a Turner's mosaic, right? So a mosaic means some of the cells are normal, some of them are missing that X chromosome, and those patients are known to be at risk of premature ovarian insufficiency or early menopause.
Well, thank you. Thank you for breaking down the three types of genetic testing patients should know about as fertility patients. Is there anything else patients should know about when it comes to genetic testing during this phase in their life when they're working with a doctor like us?
Yes, I think, the most high yield thing to talk about is pre-implantation genetic testing. I think a lot of times patients receive great counseling from their doctor, but it's hard to retain all the information. I feel like IVF patients have to learn so much. It's such a steep learning curve. And so either you may not get all the nitty gritty details because it's too overwhelming, and your doctor is not necessarily going to want to go through each part of it until it becomes relevant, or you hear about it and it's just hard to retain. So I want to go through it today. What should you expect going into a cycle where you intend to genetically test the embryos for the purpose of determining that, whether the embryo has 46 chromosomes or not? The first thing to know is that you're not necessarily going to get a black and white answer, right? There's many different types of answers you can get. The easiest answer, the one that we hope for the most, is that The embryo is euploid, which means it has 46 chromosomes, right? And from that, if you want to know the sex, we can either blind you to that information if you don't want to know, or we can tell you if it's female or male. Then the answer we don't want to get is that the embryo is aneuploid or has the wrong number of chromosomes. And most people would not transfer that because either it's not going to implant or it's going to result in a miscarriage or an individual with medical problems, right? So you wouldn't knowingly transfer that. But then there are these in-between situations, right? There's where you get inconclusive or indeterminate results. And I think it's important to know that that's a possibility that can happen. And it doesn't mean anything about your embryo necessarily. It really is just a technical factor, because in order to get this testing done, the DNA has to be extracted from the cells, amplified. And it's amazing, we're taking very few cells from the embryo. And so it might be as limited as like 4 or 5 cells. And sometimes things go wrong when you're trying to extract little itty bitty amounts of DNA from that small number of cells. So you just might not get a call with confidence of whether this embryo is normal or not. And you have options. You could say, okay, I'm just going to use that embryo or have it on the back burner and just, I'll use that maybe last because I don't have information about it. Or you might choose to rebiopsy it. We can thaw the embryo, we can rebiopsy it, refreeze it. And we don't have a lot of data on what that does in terms of, the effect it may have on the implantation rate of that embryo. But it's reasonable to assume it's not a wonderful thing to expose it to an extra freeze and thaw and an extra biopsy. So it's not something that I love to do, but if a patient is at high risk of having an abnormal embryo, it might be the right call. So that's an individualized decision and conversation you should have about whether to rebiopsy the embryo. The other in-between situation that can arise, and this is a major hot topic in our field, and it has been for the last couple of years, is when you get a mosaic embryo. And a mosaic means just like, pretty tiles on a wall or, a table. It means different. It's a pattern where you can have some normal cells mixed in with abnormal cells. So that 4 to 9 cell sample that was sent off for testing, there were some abnormal cells that were detected in there, but it's this in-between result because there are some normal cells. And that's a very gray area. And it's important to know that we don't know everything there is to know about mosaic embryos. They do have reproductive potential and they can be transferred, and it just depends on the situation. There have been live births from mosaic embryos. There have also been conditions, that pediatricians will talk about that we know can be traced back to, okay, well, the karyotype for that child with that developmental disorder or disability is mosaic, right? So there are risks that you take on when you transfer a mosaic. If you were considering transferring a mosaic, you would have to talk to your doctor. Every clinic has its own policy. There are some clinics that may say we don't transfer mosaics at all. We're very risk averse. We don't want to be involved in anything that might result in an unhealthy child, and we don't know enough about this. Then there are clinics that are much more liberal, and then there's the in-between. Where I work currently, our policy is that we will transfer a mosaic embryo if it's the only embryo you have. But if you have a healthy embryo, we would prefer that you use that first. So it's important to, I think, address what the policy is before you go into a cycle, because you never want to be in a situation when, if you find yourself, with only a mosaic embryo, not being able to transfer it, if that's something that you might want to do. I think it's important to talk to a genetics counselor because there might be some literature and some information about that particular type of mosaicism, depending on what chromosomes involved. They can also tell you things like the level, how many abnormal cells versus normal cells, the percentage wise, and what the risk could be as a result of that. So it's a complicated thing, and it's just important to know that it exists. And don't expect to just have this binary yes or no, normal or abnormal result.
Super helpful, and I wish everyone could listen to this who is doing PGTA so they can understand what information you might get. I think knowing that it could be inconclusive, knowing you can get a mosaic embryo and what it could mean for you in the future, I think is extremely important, because you don't want to find that out later that your center won't transfer a mosaic or won't even tell you if an embryo is mosaic or not. I mean, I think that could be really tough on people to find out that potentially that information wasn't given to them when they might have made a different decision and not have discarded a mosaic embryo and it was called abnormal. So thank you for that. So Lucky, thank you so much for being on today. It was so awesome talking to you about genetic testing. I hope you'll come back on. And can you tell our listeners, awesome, can you tell our listeners where can they find you?
So, if you want to be my patient, you can find me at RMA of New York in New York City. You can find me on social media on Instagram at lucky.sekhon. And as Dr. Amy mentioned, I do have my personal website, my blog, www.theluckyegg.com, and I'm continuously building it. So if you have any ideas for topics I should cover or questions, please feel free to reach out.
Thank you, Lucky, for joining us today. I really appreciate your time, and I can't wait to have you back on.
I am so excited. Thank you for having me. This was great.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Abazadeh.
And you have yet another success story.
Just launched by an East Bay fertility doctor.